I'm Steve Higgins, the director of the Vermont Center on Behavior and Health, and I want to welcome everybody who's here in person and those who are joining us online for a wonderful lecture in our monthly lecture series. As you see in the slide behind me, we have Robert Schnoll presenting today, and I'm going to have Eli Klemper come up and do a more detailed introduction of Robbie, but let me just assure you he's an outstanding investigator, very accomplished, and it's really a gift for us to have him with us today. So Eli.
Thanks, Steve. So it's my pleasure to introduce Dr. Robert Schnoll, who's a leader, an outstanding leader in nicotine tobacco research and a longtime contributor to advancing the evidence-based strategies for smoking cessation. So Dr. Schnoll is a professor of psychiatry at the University of Pennsylvania and directs Penn's Center for Interdisciplinary Research on Nicotine Addiction. He also serves as associate director for the population science at the Abramson's Cancer Center and is a senior fellow in the Cancer for Public Health Initiatives. Dr. Schnoll earned his PhD in experimental psychology from the University of Rhode Island and went on to complete a fellowship in cancer prevention and control at Fox Chase Cancer Center. He later joined the Fox Chase faculty in population science before transitioning to Penn in 2005, where he's built a nationally recognized program of research focused on tobacco. His work centers on developing and refining treatments for nicotine dependence, including novel interventions, optimizing current pharmacotherapy, and advancing clinician-delivered tobacco treatment. Much of his work is also focused on clinical populations disproportionately burdened by tobacco, including people with HIV, cancer, and serious mental illness. Dr. Schnoll's impact on the field is really reflected in his extensive publication record and grants. He has authored over 200 scholarly articles and book chapters, and has been principal investigator on well over 20 NIH-funded grants. He's provided scientific leadership at organizations such as NCI, American Cancer Society, and participated in over 100 NIH study sections. He's also played major roles in the Society for Research on Nicotine and Tobacco, including serving as program chair. So it's my pleasure to welcome Dr. Schnoll. Thanks so much for joining us today.
Great. Thanks so much, everyone. Thank you for coming. Thank you, Steve. Thank you, Eli, for having me. It's a great honor to be here. And on a personal note, it's a great pleasure to be here. My son is in the audience, who's an undergrad here, and a great pleasure to have him here and forcing him to listen to me for at least the next hour. So thanks so much for that great introduction. And let me tell you. Yeah. All right. Here we go. Okay, so this slide really summarizes the challenge of our lab at the University of Pennsylvania. On the top right, you see the rates of smoking over the last several decades, and it's certainly been a great public health achievement for us to see the rate of tobacco use decline so significantly from about 50% back in the 1950s to about 18% in 2013. And now it's around 11%. But what I hope you take away from that slide is that there's been a real plateauing of the rate of combustible tobacco use in the last decade. And we really need sort of new, novel, innovative ways of sort of reigniting the kind of progress that we saw over 50 years ago going forward. And in our lab, we really focus on two objectives to kind of reignite this progress. First, shown on the right are the rates of quitting smoking when people try and use FDA-approved medications. And you can see highlighted in red that best case scenario is that only about a third of smokers who we are able to convince to use these medications are able to successfully quit smoking. And then a second challenge shown on the left is that most smokers who are trying to quit actually don't use evidence-based interventions in their quit attempt. Highlighted here in the red, about 40% of people here don't use any treatment in their attempt to quit smoking, really use cold turkey, and about 20% use vaping products, which currently are not FDA approved for smoking cessation. And then lower are nicotine replacement therapies, our counseling programs, are prescription medications like varenicline and bupropion. Only about 15 to 16% of people use these medications. So the challenge that we have in our group is to improve the effectiveness of treatments for nicotine dependence, optimize these interventions, and to improve the rate at which smokers who are trying to quit are using evidence-based treatments in their attempt. So just to give you a sense sort of more broadly of the work that we've done to improve treatment effectiveness, I sort of lump our work into four general categories. First, we've really examined the benefits of extending duration of treatment. We've done a lot of work around particularly nicotine replacement therapy, and a lot of this work has gone into changing FDA labeling for nicotine replacement therapy to allow extended use beyond 8 or 10 weeks. We've focused a lot of our work around special populations like cancer patients, folks with HIV, folks with serious mental illness, pregnant women. So these are populations that show particularly high rates of tobacco use and particular risks associated with smoking. And then we've really been involved in pharmacogenetics of nicotine addiction treatment. We particularly focused on understanding variability in nicotine metabolism and developing what I'll define for you in a moment, called the nicotine metabolite ratio, to understand a range of phenotypes of how people smoke and respond to treatments. And then finally, over the last number of years, we've really focused on this idea of treatment adherence, trying to understand the rate of treatment adherence, predictors of treatment adherence, it's the degree to which it predicts outcomes, and validating self-reported measures of treatment adherence. So the first line of research I'm going to talk with you about is focus on optimizing the effectiveness of treatment. And what we've really focused on is personalizing the selection of medications based on variability in nicotine metabolism, and secondly, increasing treatment adherence. So optimizing what we can give people in a personalized way and with sort of added behavioral counseling focused on adherence to see if we can improve upon the kinds of quit rates that we see when people just use medications on their own. So the story I want to tell you in this area really focuses on tobacco use among people living with HIV, because the rates of tobacco use in this population are significantly higher than the general population. You know, we as I've mentioned, we've done a great job at driving down the overall rates of tobacco use to about 10, 11%. But in the HIV population, you see 30 to 40% of individuals smoking cigarettes. So it's about 3 times what we see in the general population. There's also a lot of clinical relevance to focusing on folks with HIV. Studies show now that individuals who are managing their HIV, meaning their viral load is suppressed, they're adhering to their antiretroviral therapy, but if they smoke, they lose about 12 years of life compared to those who are managing their HIV with an antiretroviral therapy but are not smoking. And then finally, we've shown and others have shown that the folks with HIV that smoke just don't respond to the treatments that we have available to them in the same way. Here's data from a couple of our studies showing both for NRT and for varenicline that the quit rates are almost half for folks with HIV than they are in the general population. So our work focused on personalizing tobacco treatments has focused on how tobacco is metabolized. And I've been really fortunate to work with national leaders in pharmacokinetics of nicotine addiction, shown here, Rachel Tyndale, Karen Lerman, and Neil Benowitz. Close to about 90% shown up here on the left of tobacco, when you have a cigarette, is metabolized through a particular pathway that involves breaking down through the liver enzyme CYP2A6 of nicotine to 3-hydroxycotinine and then to 3-hydroxycotinine. And in general, faster nicotine metabolism is associated with greater smoking rates, greater nicotine dependence, greater nicotine withdrawal, higher craving, and cue reactivity. The rate of nicotine clearance is associated with genetic alleles. So there are alleles of CYP2A6 that can inactivate the metabolic pathway, so essentially turning it off, slowing down the metabolic breakdown of nicotine. So in the general population, we have fast metabolizers and slow metabolizers based on the genetic alleles for CYP2A6. But nicotine metabolism is also influenced by a range of environmental factors. like race, gender, whether you're taking a medication that influences estrogen, mentholated cigarettes also influence the rate of nicotine metabolism. So as a consequence, we have developed and validated what's called the nicotine metabolite ratio, which is a value of that's a ratio of cotinine to 3-hydroxycotinine, and as the value goes closer to 1, that means you're a faster metabolizer of nicotine. A value of 0 represents slow rates of nicotine metabolism. And about 10, 11 years ago, we looked at how variability in nicotine metabolism influenced response to smoking cessation treatments. So shown here on the bottom right is a patch versus spray study that we had done. And in addition to collecting all kinds of the sort of standard data that we collect, we also collected, I think in this case, a urine sample, and we were able at baseline to characterize our smokers as slow or fast metabolizers of nicotine based on the NMR, and we've stratified NMR based on quartiles. So the first quartile in these distributions are the slow metabolizers, and the fourth quartile are our faster metabolizers. And what you can see in the blue bars, that's the patch arms, that there's a steady decrement in the rate of cessation. This is the rate of 7 to 8 point prevalence abstinence confirmed with a CO measure. So the slow metabolizers, they're showing quit rates of 45%, 50%, but our fast metabolizers are showing quit rates that are closer to 25%. Interestingly, the pink bars, that's spray arms, you see that overall the rates of cessation in the spray arm are lower than the patch arm. A lot of that has to do with the sort of challenge of taking a spray and so the noxious elements of taking a nasal spray. But the rate of cessation across the quartiles was the same. And that's because the folks in the fast quartiles, in the higher quartiles, the fast metabolizers, were able to take more doses of the spray in order to compensate for their higher rates of nicotine metabolism. But this was the first study that sort of gave us insight that this characteristic of nicotine metabolism could be used to understand how people respond to different treatments for nicotine dependence. So we've been really exploring this in our HIV population. We sort of serendipitously came upon this where we had collected NMR in ongoing studies with folks with HIV. This work has really been led by some graduate students and fellows in our lab, shown here. And up on the top left is sort of the first study that showed that folks with HIV tend to be faster metabolizers of nicotine than the general population. We've actually replicated. You can sort of see that folks with HIV are overrepresented in that fourth quartile of our distribution. So they tend to be faster metabolizers of nicotine compared to the first quartile. And we've replicated this independently in several different cohorts at this point. So we think that there's really something there. So we really started to sort of dig into this. Well, why is it? Could it have something to do with the virus itself? So becoming seropositive. So on the bottom left, a little bit hard to see, it's a spaghetti plot. This is data from large cohort studies that had biosamples collected from folks prior to becoming HIV and after they had become HIV positive. And so we were able to see and they were all smokers. So we could see what their level of nicotine metabolism, what the rate of nicotine metabolism was from before they had HIV to after. We found no relationship. We've looked at this in a couple of different cohorts now. So we're pretty convinced that it doesn't have something to do with becoming HIV positive. But in a couple of different studies now, we've looked at the type of antiretroviral therapy that they're taking. And this one class of medications, these efavirenz-based antiretroviral therapies, we've now seen in 3 different independent studies that if you're on an efavirenz-based antiretroviral therapy, you tend to be a faster metabolizer of nicotine. So there may be something that we're doing to treat folks with HIV that's upregulating nicotine metabolism and making it hard for them to quit smoking. So a second factor I want to mention is adherence. Probably this is not news to anybody in this room, but it's really hard to get people to take the kinds of treatments, adhere to the treatment that we give them. This is data sort of summarized from a bunch of different studies from our group that looks at varenicline adherence rates. So you can see only about 44 to 62% of our folks that we give varenicline take 80% of the medication or more, which is how we define being adherent. And we know that's highly associated with quitting smoking. On the bottom right are CO confirmed quit rates for these folks with HIV given varenicline, adherent versus non-adherent. So if they don't take 80% of the medication, quit rates are about 19%. To take 80% or more of the medication, our quit rates are 35%. So again, there may be something to do with getting people to adhere to their medications that can optimize treatment. So how do we go about optimizing treatment based on nicotine metabolite ratio and adherence? Well, we conducted a large study a number of years ago that looked at the idea of personalizing the selection of nicotine treatments based on the nicotine metabolite ratio. This was a study where we randomized up front, we characterized our smokers as being fast or slow metabolizers of nicotine. And then we randomly selected them to get a placebo condition. So they got a placebo pill and a placebo patch, a varenicline arm, so a real varenicline pill and a placebo patch, or an NRT arm, they got a real NRT patch and a placebo pill. And then we looked at quit rates stratified by slow or fast metabolizers of nicotine. And this is our end of treatment and our 6-month follow-up. And what I hope you can see is for the slow metabolizers, you can treat them with the patch or varenicline, made no difference. But if you're a fast metabolizer of nicotine, you really only responded to varenicline. And what's interesting about this study, well, I think there's lots of things that are interesting, but this effect, this pharmacogenetic effect. So we think of these pharmacogenetic effects as being relevant to when you're actively on treatment, but it actually was maintained to 6 months. So even 6 months later, our fast metabolizers were not effectively treated with nicotine patch, but they were with varenicline. We also looked at side effects. Importantly, our slow metabolizers were reported significantly higher side effects on varenicline versus nicotine replacement therapy. And we also looked at the costs associated with treating our everyone on varenicline or tailoring. And we found that we could reduce the costs if we tailored the selection of treatments, giving slow metabolizers the patch and fast metabolizers varenicline. So about adherence, I was fortunate to work with Robert Gross, who's an infectious disease doc, HIV specialist, and an adherence specialist at Penn. And he developed a behavioral intervention called managed problem solving, which is a multi-session behavioral counseling intervention focused on working individually with people to understand the potential root of their inability to adhere to their antiretroviral therapy. And he developed this iterative problem-solving intervention and tested it versus just a generic behavioral intervention. And what you're seeing up here are not just adherence rates, but this is actually viral load rates here. And what he showed here, that sure, self-report, if you gave people this managed problem-solving intervention, they reported higher adherence, but that higher adherence was validated by showing that viral loads were lower in folks that got this behavioral intervention focused on adherence. So what we've done is we're in the last year of this clinical trial. This is a study I work with. I have a close colleague, Brian Hitzman at Northwestern University. And this is a study where we are randomizing folks with HIV to receive standard intervention. So everyone gets varenicline and our standard CBT-based behavioral counseling without any focus on adherence. Or they get our optimization arm. So where we test individuals to determine what their nicotine metabolite ratio is. If they're a slow metabolizer, they get the patch. If they're a fast metabolizer, they get varenicline, and they get this additional managed problem-solving behavioral counseling intervention to address adherence. We're about 85% through our intervention. If you invite me back, maybe another time, I'll share with you the results. But we hope to have the results for this study in the next 10 months or so. So other work that we're doing in the optimization space of our intervention work, I really had the great pleasure of collaborating with Li-Shin Shen and Alex Ramsey at Washington University. And her team is testing the integration of tailoring the selection of treatment based on the NMR, as well as variants in nicotinic acetylcholine receptors, which are similar to the nicotine metabolite ratio, can be used to tailor the selection of treatments. on increasing cessation for patients in primary care. So primary care clinics are randomized to receive either just usual care, where they're getting a medication and behavioral counseling, or this precision treatment, so that we can see if we can translate the results of tailoring the selection of treatments into clinical care to improve effectiveness. We only have about half of our sample collected. Again, a follow-up opportunity to come back, I'll share with you the results. So one final example of our optimization effectiveness work is work, again, Robert Gross and I, with our colleague Billy Tsima, are working in Botswana. We've just finished this clinical trial. Again, this is smokers with HIV. As I'm sure no surprise to anybody here, high rates of HIV in sub-Saharan Africa, and there's really no available treatments for tobacco cessation. There's really no opportunity to do our sort of pharmacological interventions there. So we developed a new behavioral intervention that merges Robert's managed problem-solving intervention with behavioral activation. And behavioral activation is an intervention focused on behavioral economics to try and understand ways that we can improve rewarding activities for individuals when they're going through the withdrawal process of nicotine, to try and offset the kinds of adverse behavioral experiences that people can get when they're trying to quit smoking. We developed this intervention, we pilot tested it in Botswana, and we just finished this very large clinical trial where we're comparing standard CBT, standard counseling, to this behavioral activation and managed problem-solving intervention. And for folks like me who do these population-based clinical trials, especially for special populations, to get a sample of 651 in this clinical trial was really astounding, with tremendous adherence rates and follow-up rates. A lot of it has to do with the infrastructure that's been built in many of these countries in order to develop and provide HIV care, that we were able to layer our behavioral interventions and recruitment and follow-up onto. So we're analyzing our data right now, and we hope to have our final data ready maybe for a rapid presentation at SRNT coming up next year. So let me shift a little bit and tell you about the work that we've been doing around implementation science, focusing on that second challenge around getting people who are trying to quit smoking engaged in evidence-based interventions rather than sort of going it alone. So for those of you who are new to implementation science, it focuses on developing and testing intervention to shrink the gap between what we know works for a particular problem and what people are actually using to address that problem. And we address that both from a patient perspective, to get patients engaged in evidence-based interventions when they're not, and also from a clinician perspective, to get clinicians engaged in providing evidence-based treatments when they're not. So I mentioned before, smokers trying to quit are more likely to use non-evidence-based interventions in their quit attempt. So we've been using this as a model for addressing tobacco use. And then there's been a great deal of work here applying behavioral economics to understand how to address tobacco use. And our approach is really focused on two areas. So the first is to understand these heuristics. So these are kinds of thought processes, biases, patterns of thinking that people engage in when they're faced with complicated decisions. And certainly in clinical health-related situations, people are faced with a lot of complicated information, and they can fall back on biases like status quo bias or culpability bias or focusing effect bias that sort of derails and undermines effective decision-making. And so we've done a lot of work to try and understand what heuristics are playing out in certain clinical encounters, like treating someone for tobacco use, and then to develop messages to try and target and overcome those heuristics. And then the second area of our focus for behavioral economics is on a more system level, where we've been working with our electronic health record and other digital platforms to sort of tinker with what people see, using defaults and integrating our frame messages to push people into the right direction in making informed decision making. So our guiding our choices through default and framing information is how we're using behavioral economics to try and shape behavior. And here are just a couple of examples that we're seeing this more and more pop up in our world. Here's a example from these are both examples from the UK. Here's one where they painted the stairs, with piano keys to try and encourage people to walk up the stairs. And I'm sure you can't see it back there, but as you can appreciate in the UK, this is an intervention for parks to reduce the amount of tobacco butts that are found and that people discard. And you can't see it, but one box is Ronaldo and one box is Messi, and you're voting for which soccer player is you think is the best player in the world to try and encourage people to put their cigarette butts in there. So you're sort of seeing this this behavioral economic nudge phenomena infiltrating our world. If you watch Netflix, at the end of an episode, there's a thing that says pushes you right to the next episode. Well, that's a behavioral economic strategy to get you to continue streaming their content. So a few years ago, we were really fortunate to be one of 7 centers that was supported by NCI to study the application of implementation science for improving the quality of cancer care delivery. Our center supported 5 different clinical projects shown up here. Of course, one was focused on tobacco that I'm going to tell you a lot about. But then we had these sort of cross-cutting methods projects. One in particular, Methods Project 1, focused on using qualitative methods to understand what biases were activated in clinical encounters so that we can frame our messages, so we can create these messages that were integrated into the digital platform. So throughout all of this work, we start off with this formative work using qualitative methods to sort of guide the content and design of our implementation interventions. The center, we were certainly not the first people to talk about behavioral economics for improving healthcare delivery. We were sort of standing on the shoulders of giants, in particular David Ash, who many of you know, and Kevin Volpe, who run our Center for Health and Behavioral Economics at Penn. So we have a large sort of culture of doing this kind of work. The work that also we do is really pragmatic in nature. So we're able to get waivers of informed consent so that we don't have to consent any of our participants, including clinicians and our patients. So the work I'm going to share with you, where you see these giant sample sizes, we're able to do because we can get a waiver and informed consent and push our interventions out through our digital platforms automatically. And we do this through our large health system that has over 20,000 patients a year. We're all on the same Epic system across multiple states, hundreds and hundreds of clinicians. And then I also want to mention the critical role that informatics plays in doing this kind of work. So Pete Gabriel is our chief informatics officer for our cancer center, and we really work shoulder to shoulder in understanding how we can integrate the work that we do, including electronic phenotyping. So one of the big challenges with doing this work is identifying the people who we need to intervene with. And it's a complicated process, particularly when we get outside of tobacco into other kinds of practice gaps, where we use some more novel approaches, including machine learning. So let me tell you about the tobacco project that we have. Again, as I mentioned, there's a methods project that cuts across these studies, and we use focus groups and stakeholder interviews to determine which bias was activated in the context of tobacco use treatment. And then this informed the kind of work that we did. So when we did this work, omission bias was really activated when we interviewed our clinicians and tried to ask, and when we asked them, what's keeping you from providing tobacco treatment to your cancer patients? Omission bias was really what emerged. And then for patients, it was status quo bias. So we took that information and we built these systems. What you're seeing here, for those of you who have Epic experience, this is a best practice alert. So what we could do is we can identify our patients who are smokers and they're coming through a clinical operation. They're seeing a clinician. That clinician was randomized to what we call here our clinician nudge. That clinician received this message popping up on their screen, and they had to respond in order to move forward with that clinical encounter. 72 hours before the patient was seen, they got that message that focuses on status quo bias that was pushed out to them through, we have a patient portal called My Penn Medicine, helps you manage all of your clinical encounters and follow-up care. So they would get this message 72 hours that encouraged them to talk to their clinician about tobacco use treatment. So this first study was led by my close colleagues, Frank Leone and Brian Jensen. It was a 4-arm pragmatic cluster randomized clinical trial. So our patients and our providers were randomized to either usual care, so nothing happened as that patient came through, a patient nudge, so they got that message through their MyPen Medicine, the clinician nudge, the clinician got the message, or we have a combined nudge arm where both the clinician and the patient got that message. This work is also tends to be cluster randomized, which means that clinicians work together. And when clinicians work together, you can have a methodological bias if you're randomizing those people to different arms of your study. So we do a lot of work up front to identify what clinicians work together, and then we randomize those clinicians, 246 of them, into our 4 arms. And then we let this run. We identified our patients. We stopped it when we reached 2,146 patients who came through clinical encounters. And what we found, shown here on the right, this is the odds that a patient would be engaged in tobacco treatment, either behavioral counseling and or pharmacological intervention. And what we found was that the clinician arm in particular led to a greater than 3-fold likelihood that that patient would be treated with tobacco use compared to our usual care arm. We did some sub-analysis to look at what kind of clinician was most likely to respond. In fact, our APPs, these are like nurse practitioners, they're much more responsive to this. The engagement rate was 48% among those compared to 31% for our oncologists. And then importantly, we didn't see a disparity. So our African-American patients versus our white patients were just as likely to have been treated, engaged in treatment by the clinician arm. So this study showed that we can use informatics and formative research to develop these nudges, in this case, targeting omission bias for the clinician as an effective transferable way of implementing a strategy to increase engagement in tobacco use treatment across the cancer service line. And we see tens of thousands of patients, and we now have this nudge continuing on, and it's transformed how we address tobacco use treatment across our cancer service line. So just 2 other quick examples. I want you to take away the message that this is transferable to other clinical practice gaps. So a serious illness conversation is an evidence-based practice that clinicians are supposed to engage in so that their patients have their wishes for end-of-care treatment documented in the electronic health record. So we use the same kind of design, a 4-arm pragmatic cluster RCT, patient nudge, clinician nudge, both nudge, usual care. In this study, the combined nudges significantly increased the documentation of serious illness conversation. Third study, we just finished analyzing our data, focused on the use of MRIs for women that have very dense breasts to improve breast cancer early detection. This was a 2-arm, this is slightly different, 2-arm pragmatic step wedge design. So step wedge, you gradually roll out the intervention across your clusters over time. This was integrated into primary care primarily. And in this study, the clinician nudge led to a 2-fold increase in the rate of scheduling, ordering, scheduling, and completing MRIs versus usual care. So increasing it from when we started doing the studies, about 7%. Now we're up to about 20% of women receiving MRIs for early breast cancer detection. So we're doing, we're now translating this work into HIV. So we're using the same kinds of designs, a pragmatic study, 2x2 clinician patient combined versus usual care arm to integrate our best practice alert and our digital platform nudges to patients to improve engagement in tobacco use treatment for our HIV patients throughout infectious disease clinical service at Penn. We're going to launch this study in January. We've done some work to integrate the nicotine metabolite ratio into primary care and into lung cancer screening. This is work led by Frank Leone and Scott Siegel, who's down at Christiana Care down in Delaware. And so Frank and Scott have done these small pilot feasibility studies at this point. In primary care, we compared a cohort of patients provided with just usual care versus those who were screened for the nicotine metabolite ratio. And the clinicians received this best practice alert when the patients were coming in for treatment that informed them if they were a slow or fast metabolizer of nicotine and provided a concordant recommendation for what kind of medication they should use. We didn't see an overall increase in the rate of using medications, but we did find that clinicians were very responsive to this personalized treatment. 26% only our fast metabolizers receive varenicline, and 26% of our fast metabolizers receive medication versus 0% of our slow metabolizers. And then in our second pilot study, Scott is testing if nicotine metabolite ratio based treatment recommendations integrated into lung cancer screening improved treatment engagement versus just providing access to treatment. Overall, the rates of treatment were the same, but the ability to tailor the selection of NMR-based feedback led to improved treatment matching. You can see our treatment matching was about 80% versus 45% in our usual care arm. So this is just some initial piloting work that we're doing to try and translate our nicotine metabolite ratio as an implementation strategy into different clinical settings. Someone asked me about, or it came up about something about Rutgers. And this is an older study that I did with Doug Zadonis and also with Frank to integrate an organizational intervention into community behavioral health. So as many of you know, smoking among folks with serious mental illness is 2 to 3-fold versus the general population. There's lots of barriers in clinical operations like staff and leadership perceptions, lack of staff resources, lack of knowledge and skills, and inadequate policies. So Doug Zadonis developed this Addressing Tobacco Through Organizational Change. We did a cluster randomized study comparing his intervention, where he came in with his team and tried to change manuals of operating procedures and change incentive structures within these community behavioral health organizations versus just a usual care training organization. We found that in clinics that received ATOC, tobacco treatment and staff skills went up without worsening patient mental health, which is a big barrier to doing work in this setting. One of the last examples I want to share with you is work that Brian Jensen is leading. We have a children's hospital affiliated with our main medical facilities at the University of Pennsylvania. It's separate, but we're highly collaborative. So Brian is a pediatrician and an informatician, and he's been really leading our efforts to leverage pediatric primary care to address parent smoking. So he had a KO8 first that he did discrete choice experiments and formative work to sort of understand how to guide our EMR-based nudges into clinical operation. And then in the last 3.5 years, his work has led to an astounding 500,000 assessments of tobacco use and a quarter to a third of parents who are engaged in tobacco treatment. And then he leveraged this work to integrate these nudges into primary care in the pediatric network, and he got an R37 that he's now evaluating the system to include varenicline and to recruit all household members who smoke into this clinical intervention. This is but last slide, or second last slide. So we are doing work in other aspects and other clinical settings. I'm working with Matt Carpenter, who many of you know, Larry Hawk, Jennifer Dane, Karen Cropsey. We were able to get funding from NCATS, the National Center for Translational Science, I think it's called, where we are formally testing the idea that scientific rigor isn't there's no degradation to scientific rigor if we do all of our intervention work remotely versus in person. And we're doing 3 different studies. We're doing a tobacco study and then one on opiate overdose prevention and depression screening, hoping to show that if we do our tobacco study completely remotely, that we get the same pace of accrual or same representativeness of accrual, retention, fidelity, and follow-up assessments. And we're more than halfway through our tobacco project now, and we'll have that done in the next year. And then finally, we really leveraged some of the work. I didn't talk about a breast and ovarian genetic testing project that we're doing in our P50, but we leveraged that work to then get a new R01 from HGRI that is adopting the same kinds of methods and models of implementation science and behavioral economics to test ways that we can improve the rate of genetic testing for Alzheimer's, Parkinson's, cardiomyopathy, other kinds of neurological conditions where we know there are genetic tests that can guide improved treatment delivery or surveillance. We're about 80% through that study at this point. So just to summarize where we're headed hopefully over the next few years, we just received 2 new grants. One is an R25 that Frank Leone is leading, that's integrating our tobacco treatment training and implementation strategies across high priority populations. So that's folks with HIV and folks with serious mental illness. We just got this UG3-UH3 that's going to carry on the work that we're doing to address tobacco use in oncology, to test a point of care versus a refer to specialist model, and then methods to sustain that work after funding goes away. As I'm sure many of you in this room have grants that were funded, and who knows what's happening to them. So we have a U01 that we had submitted and gotten a great score on, and focused on implementation of genetic testing for a range of other conditions through primary care. But we're not really sure what's happening with that grant at this point. We're sitting back and waiting. And then we have 3 grants that have been submitted. One is cytosine. So many of you are familiar with, it's called cytisinicline now by this Achieve Life Sciences. But cytosine has been around for 40 years. It's a plant-based alkaloid that's similar to varenicline. It's also about $100 for a full course of treatment. So we think it's really ideal for testing in Botswana. So the renewal of our Botswana project focuses on cytosine and adherence counseling for improving tobacco treatment for folks with HIV in Botswana. I mentioned to a few folks earlier that we're translating some of this work in behavioral science and implementation science in behavioral economics and implementation science to address alcohol use, which is also an important cancer risk factor, and we just submitted that grant. And then we had a T32 was supposed to be reviewed tomorrow. They told us it's not going to be reviewed tomorrow, so we'll see what's going to happen with that. But the focus there is on implementation science and training. So importantly, it's intentional that when I talk, I always use plurals for the things that we do in our work, because you can see how many people are involved in doing this work. I certainly do far less than what's reflected. My name's just on the title slide. And then, of course, all of the funding that we received from our NIH partners and from the University of Pennsylvania. So thanks so much for listening. I'm happy to take questions.